everybody, and welcome to the first academic meeting of the year. And we're starting with a bang. Some proper science, I think, is going to happen here today from our clinical scientist, Lyle Murray. So I think you all know Lyle, but just a little bit of a background. Lyle started off with his PhD. I mean, that's what you're supposed to finish with, right? But Lyle started with his PhD and then became a physician, and then specialized in the most important subspecialty, which is infectious. And as you can see, infectious diseases forms a part of many other disciplines as well. And I think it's important for us to be aware that everything we prescribe has an effect on many other systems. And Lyle is going to give us a little bit of an overview of that. Okay.
Thanks, Sarah. So I'm really talking about biologics, DMARDS, and infectious diseases, but it's really more about kind of common immune suppressive medications and what the risks are of infections associated with them. So I'll go over what DMARDS are. I'm no rheumatologist, but I'll go through what I've picked up as an understanding of what they are, and it's actually more complicated than you think in terms of what the definition is. We need to understand what our immune system does before we can understand exactly how different drugs impact the immune system and how they impact our susceptibility to infections. So then thereafter, we'll go through how specific medications affect immunity, and then what infections people are really susceptible to, and then really what we can do about it after all of that. So a few definitions to start off with. An immune suppressive agent is really something that inhibits or decreases the intensity of an immune response. So that's quite self-explanatory. And generally, we use immune suppression for a bunch of different reasons. Sometimes it's to suppress an immune response. It's causing autoimmunity. It's trying to suppress your immune response when you've had an organ transplant and you're trying to prevent the host from rejecting a donor organ. Sometimes it's about dampening an immune response or using for cancer therapy, and sometimes about dampening an immune response to a pathogen like TB or to possibly other immunological therapy in terms of an immune reconstitution and inflammatory syndrome. So I've explained what an immune suppressive agent is. So DMARD is really a disease-modifying anti-rheumatic drug. But exactly what the DMARD is compared to what is just an immune suppressor is not very clear. So I'll try to go through that. We divide DMARDs up into conventional DMARDs. So this is drugs like methotrexate, leflunomide, sulfasalazine. And then there's biological DMARDs. So these are drugs like infliximab, adalimumab, etanercept, etc. So conventional DMARDs I mentioned, and then biological DMARDs. So the difference between them generally is that conventional DMARDs are very non-specific. They target things, the immune response quite broadly. They're generally a lot cheaper. They're generally synthetic drugs, and that they are normally used as an introductory therapy or first choice of treatment before moving on to biologics, and when you're looking at using immune suppressors, particularly for autoimmune disease. Whereas biologics are far more specific. They target a specific immunological pathway. They can be antibodies, chimeric antibodies. They can be fusion receptors or small molecules. And when they term biological, we mean they generally initially were produced by living cells. Although now we do have some synthetic biological DMARDs, which confuses things a little bit. So conventional DMARDs, as I said, hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Glucocorticoids are not specifically DMARDs, but they are, of course, immunosuppressive agents. We can subdivide further into antimetabolites. So these are drugs like azathioprine and MMF. Some people would classify methotrexate as an antimetabolite as well. Your calcineurin inhibitors like cyclosporin and tacrolimus. And then your mTOR inhibitors, things like sirolimus and everolimus. So biological DMARDs can be routine, normal biological DMARDs. They can be biosimilar biological DMARDs, or they can be targeted synthetic DMARDs. So as you can see, it does get a little bit more complicated, but hopefully it becomes more clear. So biological DMARDs are things like rituximab, Biosimilar biological DMARDs are really just generics of biological DMARDs. So there's really very little difference. It's just where the original proprietary drug was created, then someone really copies it and creates a generic, but you can't call it the same. It's then called a kind of biosimilar biological DMARD. And then the targeted synthetic DMARDs, and these are things like the JAK inhibitors like baricitinib and tofacitinib. The biological DMARDs can be antibodies. So antibodies can either be polyclonal, so a big bunch of antibodies like polygam, or they can be monoclonal. And monoclonal antibodies target a particular target. So if they target T cells, and to target IL-2 or target TCR CD30, B cells targeting CD20, or T and B cells, so CD52. Antibodies may target cytokines, or they may target complement, or they may target leukocyte migration. There may also be fusion proteins, things like abatacept, or as I said, JAK inhibitors. So in order to understand what these do, you really need to understand what your immune system does in the first place. So you've got different components of your immune system. You've generally got your barriers. So your barriers may be things like physical barriers, so like skin integrity, tight cellular junctions, mucus, cilia, lysozyme, maybe kind of chemical barriers. And any damage to these barriers can result in susceptibility to infection. Then you have your innate immune system and your adaptive immune system. So within your innate immune system, you've generally got your phagocytes and your NK cells, and then complement. And within your cellular or your adaptive immune system, you've got your cellular immune system, and then you've got your humoral, so antibody production. So innate immunity, generally the cells involved are things like neutrophils, they're phagocytes, monocytes and macrophages, and also natural killer cells. The receptors are uniform, so they are expressed by all the cells of a particular type, and the soluble factors are things like complement or cytokines, and they don't change with repeated exposure. Whereas your adaptive immune system, the cellular components are B and T cells. Their receptors are clonally distributed and very highly specific. Soluble factors involve different cytokines, and they clonally expand. So they're very specific to a particular infection. And when you get exposed to that antigen again, they clonally expand in order to be able to target a particular infection. Whereas your innate immunity generally has a broad ability to reckon with pathogen recognition receptors that will recognize things like DAMPs and PAMPs. You may have remember that from your immunology classes. So sometimes to understand what your immune system does, the best way is to look at particular primary immune deficiency examples that exist, and then look at how those patients kind of present. So where you've got a disorder of phagocytes, conditions that may mimic that would be things like chronic granulomatous disease, where there's a defect in oxidative burst. So your phagocytes are able to ingest organisms but not kill them because they're not able to activate oxidative burst. Or things like congenital neutropenia, where people are born without neutrophils. And so these deficiencies normally result in susceptibility to generally bacterial infection and sometimes fungal infections as well, in particular Staph aureus and Burkholderia and Serratia. Some susceptibility to mycobacteria as well, but phagocytes mostly bacterial and fungal susceptibility. Where there's complement deficiencies, there's lots of different complement deficiencies that involve different components of the complement pathway. And so generally this involves susceptibility to bloodborne pathogens, particularly encapsulated bacteria. So things like strep pneumonia, Haemophilus, and Neisseria meningitidis. Where there's antibody deficiencies, good examples of this might be common variable immunodeficiency syndrome or X-linked gamma-globulinemia. And these patients generally present with sinopulmonary infections, so sinus infections, recurrent pneumonias, and also GIT infections. So wherever, obviously, antibodies are primarily involved in defense. And if it's cell-mediated immunity, an example is chronic mucocutaneous candidiasis. So your cell-mediated immunity is very important for intracellular organisms. So viral organisms, fungal organisms, and then also a mycobacteria. And if you have a combined deficiency of both antibodies and T cells, then you may have a condition called SCID, or severe combined immunodeficiency. Always presents generally very early in childhood with severe infections across a very broad range. So another way to look at infections that present in patients with immunosuppression is to look at important kind of syndromes. Let's see if we can get this to come up one at a time. So one of the first groups of infections is chronic viral infections that normally require an intact immune system to control them, but for which other therapies exist. So this is things like CMV, EBV, or I guess therapy for EBV is a bit less effective, but varicella, HSV, Hep B, and Hep C. Then you have other opportunistic infections, and these are infections that really require an immune system with an effective immune response for resolution. So this is things like TB, other mycobacteria, nocardia, invasive fungal infections, and PJP as well. Another group of infections is kind of severe life-threatening infections that may involve bacterial sepsis typically. And then there are other infections that lack specific therapies for which the immune system is really the primary way of controlling them, and for which a reduction in immune suppression is really the way to control them. And that's things like BK virus, JC virus. There's no specific therapies for them, and cryptosporidiosis. That really the management is about trying to reduce the amount of immune suppression. And then there's other common bacterial and fungal infections for which normal therapies exist as well. So then I wanted to turn to now, we've gone through that kind of background. We want to look at what specific immunosuppressives particular risks are and how you may mediate those. So I wanted to go through steroids because they're particularly important, although they're not DMARDs, as I said, or biologics. They are most probably the drugs you're going to use most of all. And they're almost the most important ones to have some decent knowledge about. So you generally use them for any kind of anti-inflammatory and immunosuppressive use. They work by binding to the glucocorticoid receptor, which is intracellular, and then they alter gene regulation to reduce expression of pro-inflammatory molecules. So generally, they affect all parts of the immune system. They affect the innate, the cell-mediated, and antibody. So you can imagine, having gone through what deficiencies of within different parts of the immune system result in, you can imagine that the range of infections is pretty broad, depending very much on the dose and the duration of treatment. And I'll go through that in a bit. I find this image quite useful because it gives you an idea as to how serious or how high the risk of infection can be when you use a glucocorticoid. So if you look at conventional DMARDs right on the left in this image, and you look at other drugs like so tocilizumab, IL-6 inhibitor, or a TNF inhibitor like infliximab, those are sitting kind of in the middle. And round about the area where low dose glucocorticoids sit as well. But high dose steroids are really right on the opposite side and far more potent at suppressing your immune system and putting you at risk of infection. So it really puts into context how important steroids are in terms of their effect on your immune system. But it really does depend, obviously, on how much you're using and for how long. So we term where you have use of, say, 10 milligrams or more per day, you generally get about a double the risk of infection, of severe infection. We talk about long-term use as anything longer than 4 weeks. Low doses is generally 10 milligrams or less than 10 milligrams. And even at those, you do get an increase in milder infections like herpes-associated infections. So even very low doses can be associated with 1 to 2 increased serious infections among 100 patients treated with them for a year. And so that's kind of, as I showed on this image, it's similar to TNF-alpha inhibitors. But where you're using them at the dose of 20 milligrams or greater, obviously this depends on like the weight of the patient. But as a rule of thumb, for 20 milligrams or greater for a month or more, your risk of PCP and TB goes up significantly, and you really need to be considering prophylaxis in those patients. So going back to conventional DMARDs, hydrochloroquine and sulfasalazine really don't have much of an increased risk. Leflunomide, generally a big Cochrane review showed no increase in risk versus some of the other conventional DMARDs. And generally, when you combine one of the conventional DMARDs with a biologic, you don't really get additive immune suppression. But obviously, you do get issues are related with the primary biological that you're using. Methotrexate is a little different, also depends on the dose that you're using. This study was actually a cardiovascular trial where they're looking at using 15 to 20 milligrams of methotrexate versus placebo. They showed there's no increase in serious risk, but that there's a slight increase in general infection risk over the period of the trial. So this is quite a good example of the risk of methotrexate. Obviously, you can use it very high doses when you're treating malignancies as opposed to treating autoimmune conditions. The antimetabolites are as a thioprin, generally use it for autoimmune conditions and also use it for prevention of organ rejection. They interfere with DNA synthesis and cell proliferation. So they primarily affect your cell-mediated and your antibody immunity. And the infectious complications may be bacterial infections and then your viral as well as your opportunistic infections. So MMF is similar, often used as a kind of steroid-sparing agent in autoimmune disease, also used in prevention of organ transplant. Mechanism of action is very similar. Also primarily affects your adaptive immune system. And the effects are pretty similar. So risk of CMV if you're using quite high doses. Not an effect on PCP, which is interesting because it's actually almost protective. And has shown to have anti-PCP activity, and then a small risk for TB as well using MMF. The CNIs, so the calcineurin inhibitors, generally are used for the prevention of organ rejection, some T-cell mediated autoimmune disease as well. So they block transcription of activated T cells and reduce activation of T cells. So again, mostly your cell mediated. Immunity is affected, and so complications are again intracellular organisms, your viruses, and also some risk for TB. The mTOR inhibitors, this is drugs like sirolimus and everolimus, also used for the prevention of organ rejection. Has less, but some autoimmune indications as well. And they block cell cycle progression, and so they reduce T cell proliferation, also mostly affecting your T cell, but also some innate immunity as well. So again, viral infections, as well as a higher risk for PCP, TB, and non-tuberculous mycobacteria as well. So then we move on to the biologics. And these are obviously very specific to what biologic you are using. Rituximab is most probably the biologic we use the most, I would guess, here. It's generally used in autoimmune disease like lupus and vasculitis disease. Also used in some chemotherapy for some malignancies, particularly B-cell malignancies, because it targets anti-CD20. CD20 is present on all B cells. So because it binds to the CD20 receptor, it then causes B-cell depletion. And this B-cell depletion lasts for 6 to 9 months. As a result, obviously, because you're reducing your B cells, you reduce antibody. And so the major effect is on antibody. The infectious complications, so generally there's a small increase in bacterial risk, but a particular risk is for hepatitis B amongst the viral infections. Also a small risk for PML and for PCP. So you really need to be careful when you're using, particularly with regards to hepatitis B, but I'll go through that now in detail. You only really need to use PCP prophylaxis for rituximab if you're using it with another drug that has high risk for PCP. So like if you're using it with corticosteroids above 20 milligrams per day for more than 4 weeks, and you would add PCP prophylaxis. But if you weren't, you generally don't need to. But the main thing is hepatitis B. So you need to screen patients to see whether they're hep B surface antigen positive, but it's also important if they've been exposed to hepatitis B before and now are hep B surface antibody negative, or if they're hep B core antibody, if they're hep B core antibody positive, indicating previous infection, that's important as well. If they're hep B surface antibody negative, they should be vaccinated. And if they're hep B surface antigen positive, they should be put onto treatment, so nucleoside analogs. Also, if they're hep B core antibody positive, they should also be treated to prevent reactivation of hepatitis B. The anti-IL-2 drug is very much anti-T cell, basiliximab or Simulect. You really only get exposure to this if you say working in the renal transplant unit. Generally used as induction therapy to prevent organ rejection. It reduces your cell-mediated immunity, but it doesn't deplete total T cells. So actually, there's infectious complications are minimal, despite there being quite a big concern about the use of it and its impact on immunity. But generally, the infectious risks are quite small. That's in contrast to a drug like alemtuzumab, which is called Campath. I don't know if you've heard of it. It's anti-CD52. It's used for autoimmune disease, so like things like MS, but also used in malignancy. And it depletes cells that express CD52, so it generally depletes both B cells as well as T cells. And so it's really like, and its biggest effect is really on CD4 T cells. So it's basically mimics severe HIV infection. So it drops your CD4 count significantly, and the easy way to remember the immune effects of it is everyone's aware of how patients with advanced HIV present, and so those are the type of infections that patients get. So common bacterial and viral infections, risk for PML, invasive fungal infections, and then all your other opportunistic infections like PCP and your mycobacterial infections as well, even toxo. Very potent drug, most probably one of the more difficult drugs to manage, also because the immune suppression is quite prolonged on alemtuzumab. So for these patients, you need PCP prophylaxis, you need CMV prophylaxis, you need to choose what strategy you're going to use. They also need other herpes virus prophylaxis. You should screen them for latent TB and treat them as well. And for female patients, they should have annual HPV screening. Hep B is very similar to rituximab, which is basically like a combination of rituximab and a T-cell depleting drug. Your anti-cytokine therapies really depend on what cytokine you're directing it against. So a drug like anakinra targets IL-1. There's drugs like canakinumab or rilonacept, used generally for rheumatoid arthritis. The immune effects are actually relatively mild compared to some of the others. There's a bit of an increase in bacterial infection, but generally infectious risk is quite mild. So tocilizumab, you might have come into contact with it during the severe COVID period. It's directed anti-IL-6. Other drugs are sarilumab, satralizumab, and siltuximab. All of these mAbs are very difficult to pronounce. And it's used for a variety of autoimmune conditions as well as severe COVID-19, as I mentioned. It can affect your innate immune system, also some cell-mediated antibody, and its risk is really bacterial infections because it primarily affects your innate system, as well as some viral and opportunistic infections, but less so than others. And I think we saw less of a risk for bacterial infection than we anticipated when there was this huge rollout of tocilizumab during the COVID pandemic. Infliximab is a very important drug. It's kind of the anti-TNF alpha kind of poster child, but there are lots of other drugs that are also anti-TNF alpha. So used for a range of autoimmune conditions. It basically binds to anti-TNF alpha, and this really impedes mostly cell-mediated immunity. And the infectious complications are really TB. And so this is the one thing you must really remember. And if I haven't said it already, you should remember TB for anti-TNF alpha. Of course, there are some other risks as well. When you think of TB, then you've also got to think of other mycobacteria, and you also got to think of other intracellular bacteria, things like Listeria, Legionella, Nocardia as well. Along with that comes invasive fungal infections. And there's a bunch of different TNF alpha antagonists, and for us, it's very important because we have so much TB in our community. There's infliximab, which I said is kind of the poster child, but there's also adalimumab, which is used quite a lot as well. Etanercept and certolizumab, so they all have different impacts on TNF alpha, but all have a risk for TB. So if you look at the risk of TB of these drugs, it really varies from sometimes between kind of 17 times greater risk than patients who are not on TNF alpha inhibitors, to a risk of 45 times higher. But if you look at this risk, some go up to kind of 12, 17. All of these studies are from observational registries in places like Sweden, Canada, France, UK, US, which is it's not really interpretable to our setting. So we really need to be very careful. If we look at general risk of TB associated with biologics, all your generally adalimumab and infliximab are the highest risk, etanercept as well. This is all TNF alpha inhibitors, and the others have a moderate increase in TB, but nothing like anti-TNF alphas. So what should we be doing? If you're going to put someone on one of these drugs, you definitely need to screen for latent TB and treat if positive for at least 1 week before you give the biologic. I don't know why that's done that. But there's a bunch of different guidelines that suggest what screening you should do for TB according to different international kind of consensus, and what drugs you can use to treat latent TB. But in our setting, you should probably also add a chest X-ray and do a sputum gene expert as well. We have local guidelines. The South African Rheumatological Association has also created guidelines on the use of anti-TNF. And they suggest doing a TB risk assessment before you decide to put someone onto anti-TNF alpha. So a risk assessment would look at those who are high risk, or those patients who are contacts of TB cases, working or residents in an area with high TB incidence, which is, I guess, everywhere. If you're living in congregate settings, if you're a healthcare worker, so that's everyone here. If there's a history of alcohol use, people reliant on public transport. You see, if you look at any of these, it's basically everyone in some way or another. And so those that are high risk, you generally consider not using an anti-TNF alpha. Or if you are using it and you need to use it, then keeping them on a TB preventative therapy for the duration of the therapy, or the time that they're on the TNF alpha. And if they are low risk, then you can consider giving a treatment for latent TB and then stopping, but also constantly evaluating for TB risk. There's no general benefit for use of PCP prophylaxis if you're using an anti-TNF alpha. And no benefit, particularly of bacterial prophylaxis either. And if you are Hep B surface antigen positive, people should also be put onto treatment for hepatitis B. If they're negative, then you should vaccinate them before you put them on the agent. I'll shoot through these ones quickly. Anti-complement, we don't use as much. Eculizumab is an anti-complement factor 5. Its major risk, as complement is obviously involved in clearing encapsulated bacteria, so that's where the major risk is sepsis due to bacteria like strep pneumonia, Haemophilus, and Neisseria meningitidis. Inhibitors of leukocyte migration, so drugs like natalizumab. This may be useful for conditions like MS. Go through this because you're not really going to get a lot of exposure to it, but really affects your innate and your cell-mediated immunity. And the big risk is CNS, so risk of PML and risk of viral meningoencephalitis. So those are the major risks you need to consider. So there's now, as you can imagine, we're talking about the particular drugs that you are maybe using for immune suppression. But you also need to consider there's a growing thought about looking at the kind of net state of immune suppression. So, for example, we get asked generally the indications for using a urine lamp for TB to detect disseminated TB is someone who's severely immune compromised with HIV. So HIV is basically the only time you would use it. But we do get people who would come and say, well, this patient is severely immunosuppressed. They've got lupus, they're on steroids, they've just been given rituximab, whatever. Like, we think that they should get a urine lab. And so it's a reasonable thought. And so that's why I'm talking about like a net state of immune suppression. You've got to considering all the things that make someone immune suppressed. And some of that involves the underlying disease. So someone with rheumatoid arthritis, for example, is immune suppressed regardless of any other drugs that they put on. They may also have chronic kidney disease, or they may have hypertension or diabetes. These are additive factors in terms of their immune suppression. Then you put them on an immune suppressive agent or particular combinations. That's also obviously adds to the infectious risk. Then their particular environment where they live and work and their particular epidemiological exposures is also a consideration. And then obviously everyone is different, and people may have their own unique genetics that make them more or less susceptible. So it would be nice to have a way of measuring immune suppression in a way. And so it's obviously quite a difficult concept to do, and there's no very clear and efficient way of doing this. So where you're using particular immune suppressive drugs like CNIs, like calcineurin inhibitors, you may be able to measure a drug level. So tacrolimus, for example, you can check a drug level and you can infer immune suppression based on that in a certain way. You may look at immune function assays, so looking at a white cell count or differential, looking at the neutrophil count, maybe looking at immunoglobulin levels. Particular infections like CMV, or EBV, you could look at viral loads. There are other newer ways of looking at things like soluble CD30 or intracellular ATP, where low levels of intracellular ATP, for example, are associated with quite severe immune suppression and high susceptibility to infection. But these are all kind of research things that are coming along the pipeline that are not really accessible to us. And you may also be able to look at particular immunoregulatory genes using a gene array or something like that. But this is where this field is kind of going in the future. So to end off, I wanted to look at some general kind of considerations for biological use. So where this is taken from the rheumatological guidelines. So where should you use them with caution? That's basically with any active bacteria or any active infection. So particularly those patients who may have these are often rheumatological patients, so patients who've got septic arthritis or prosthetic joint with a prosthetic joint infection, chronic infected leg ulcers, persistent or recurrent lower respiratory tract infections, patients with hypogammaglobulinemia, and all these type of patients, you should really be careful and really consider prophylaxis where relevant. There's some guidelines on surgery as well. So based on when you give the drug, if it is an elective procedure, when should you do surgery and when is safest to do. So there's based on which drug, there's recommendations also from SARA that would kind of give you an idea as to when's best to time surgery if you can. And then you can obviously also consider vaccination. So generally all patients should get flu vaccinations. Everyone should have a tetanus vaccination. Any patients that are due to receive biological DMARDS should be vaccinated against pneumococcus. So a rapid way to do that is to give the PCV13 vaccination, and then 8 weeks later give the PPSV23 vaccine. And it's best to do this at least 2 weeks before you put the patient on the biologic. And then obviously Hep A and Hep B, if the patients are non-immune, it really depends on what their risks and exposures are. So if they're going to be traveling then you should vaccinate. If anyone has a risk for Hep B and they're Hep B surface antibody negative, you should generally vaccinate them. And there's different schedules you can use. You can use an accelerated schedule to try and get them vaccinated as quickly as possible before, if you want to use a biologic soon. And so that's where I'll leave it for now. If there's any questions, I'm happy to take questions. It's obviously a lot to go through, but really just to make people more aware of the infectious risk of drugs that they're using commonly. One thing to reiterate is the risk of steroids, particularly the need for prophylaxis. Another thing is TNF alpha in our setting. Those are the real take-home messages I'd like to emphasize. Thank you.